Okay, so you've just had a fantastic overview of the IMF from the origins to the future, and certainly the future looks very bright. So to follow up on what Robin mentioned, we have adjusted the program, and so our speakers will be able to get safely home and not be stranded and not show up in the clinic on Monday. So it's going to be a little bit compacted, but I think it will help everyone, and I don't think that we will lose any of the benefit of the seminar. So part of the change is that my presentation will be very brief. And basically an overview of what you'll hear today. Basically a capsule summary, a bird's eye view of the myeloma landscape. And to pick up on what Jellic was saying, I think that the thing about myeloma treatment management right now is that we've actually moved from hope to actual therapies, so many of them that are available and can really help you. And so the management of part of myeloma is which of the many options should you really be pushing for? You have some options of what we used to call novel therapies, and then we have all of the new immune therapies. Should you maybe stick with a combination of the old novel therapies like Kyprolis or pomalidomide, or should you be looking for that newest bispecific elrantamab, which was just approved this week, or talquetamab? I was thinking that on our website, I think we need to create a cheat sheet where you have a list of all these long words and then their commercial names. So talquetamab, which I'll show you in a minute, its trade name is Talvi, so I think I do prefer that. Elranatamab, its trade name is Rexfio, I think. So I think I might stick with elranatamab, actually. Anyway, so here in LA, the bird's eye view of myeloma these days is that the outlook is really amazing for this year and the next several years. It's typical for patients to have an excellent initial response to therapy, often a very deep response. And that first remission is often a very long one. On average, it can be 4 or 5 years. For some patients in the room here, it was even significantly longer than that. And then many, many effective relapse options, which are not just trivial things. Now these relapse options are very, very major therapies, which can give a long second or third or fourth remission. And it's not unrealistic to say maybe the cure is on the horizon. We have this MRD negative, minimal residual disease negative. And how long does it last? Well, we have patients out quite a number of years who are MRD negative. So I just want to give a little bit of the history so you can see the next step in the history. I'm going to give three steps in the history. So this is 15 years ago. What we had was chemo, VAD. The V in that case was vincristine. Some of you maybe took vincristine, and the A was adriamycin, and then D is dexamethasone. So in those days, we used chemotherapy before stem cell transplant. And at that point, Velcade and Revlimid, bortezomib and lenalidomide came into the picture in the relapse setting. So what happened next was, now this is just one example, but it is an example where I did happen to be the principal investigator of this study. but nonetheless, it is a good example of what happened. With Revlimid and Velcade being very active in the relapse setting, the idea that we had in SWOG is that why don't we bring those together in the frontline setting. So giving Revlimid plus Velcade and Dex, VRD. And so to do that, you need a comparison study where you compare, in this case, 3 drugs versus 2 drugs. And this showed that 3 drugs were better than 2 drugs. And so this is kind of the model of how things are moving forward right now. And so the second step was Velcade, Revlimid, and Dex, and now plus or minus daratumumab or isatuximab. That's the frontline therapy now, standard of care frontline therapy, and with or without a stem cell transplant. For patients who are not having a transplant, really fantastic frontline therapy is daratumumab or ISA plus Revlimid and Dex. And so in the relapse setting, we have what we touched on a lot yesterday, the CAR T cells, the bispecifics, but then also a lot of other relapse therapies, cell mods, and many new agents in clinical trials that are moving forward. And so what is the next step? Well, the next step is that those in the relapse box are going to move forward into that early box. So that's going to be the next step. And so why are we optimistic about that third step right now? This slide here really summarizes why we're optimistic and why you should not just have hope, but see what is tangible and right in front of us, amazing results that we're seeing with the new immune therapies. And I appreciate Tom Martin, Dr. Cherry's colleague and friend now, who came up with this slide. If you see the big bars over on the right, that's the response rate with CAR T cells, ide-cel and cilta-cel, and then the little lower bar over on the right is teclistamab, which is a bispecific. So those 3, 2 CAR T cells and 1 bispecific, those bars are way higher than anything that we've seen in the past. If you look at the far left, you've got bortezomib and lenalidomide. That's VRD. VRD is over on the left there. And we've been so happy with that. Now we have those bars over on the right. And so we just need to learn how to use those alone and in combination. And it is amazing what we're going to see, I believe. And so look at this. We're going to be talking about this for the rest of the day. What is the timeline? Well, we have a belantamab, which is in a sort of a unavailable status right now, but we have ide-cel, cilta-cel, and teclistamab, so 2 CAR T cells and a bispecific. This week, we had approval of 2 additional bispecifics, elranatamab. So if you look underneath the gray bars, if you look down to the bottom on the right, you'll see elranatamab and talquetamab. Those are the 2 new bispecifics that got approved just this past week. And so they move up besides the others. So that means that there would be 5 or 6 approved new immune therapies. And then, so what is the future like? Well, look at all those CAR T cells that are coming along. CAR T cells, not just against BCMA, but this other target, GPRC5D. And then all these other bispecifics that are coming along. And so the next step is where we have trials, where those that are available now in relapse are being studied earlier. So the trials are ongoing to see how we can move to that third step and introduce those relapse immune therapies into the earlier disease setting. And all these different trials are ongoing. Again, I think we need a cheat sheet to see, oh my God, where are all those trials? Does it fit in with my status of disease? And over on the right, you can see the list of the BCMA and non-BCMA CAR T and bispecifics. I think that this is something that struck me very recently at our ASH meeting, which may be leading towards the future, is that by combining two bispecifics. There was a first trial that was presented at our ASH meeting in December, and it's the RedirecT trial. Actually, it was presented more recently. Anyway, the RedirecT trial, TT1, which combined teclistamab with talquetamab. So two new targets. So combining two bispecifics, there was an 85.75% response rate in patients with high-risk extramedullary disease, EMD. And so this means that by combining, we're seeing this data now that combining the immune therapies, just as like what we did with BRD 20 years ago, we will be able to really focus on resistant and relapsing disease. So this is the wave of the future, and we're going to be hearing all the details about this today. Look at this list, all of the active drugs now. We certainly need to have a seminar probably every day to really make sure that everybody knows what's on this list and understand if it might at some point be important for you. We're going to be hearing all about that. And in the background, as Jellic mentioned, we have a lot of research going on with the Black Swan Research Initiative. And one trial that we are very proud of is the ASCENT trial, which was treating patients with high-risk smoldering myeloma with daratumumab, Kyprolis, Revlimid, and Dex. This has produced MRD negative in 84% of the patients. So we're pretty excited about that. And in fact, Dr. Abanar, who's going to be coming up here in just a moment, had the first patient in this particular trial who is, I hope and I think, still MRD negative. Yes? All right. We don't need to talk about this. We talked about this yesterday. We need to track, as I was talking about in some detail yesterday. And so with that introduction, I think that you can see that we've gone beyond hope towards so many different options that we need all of our experts that we have here today to try to explain what would be the best way forward for each one of you individually at your stage of disease. So with that, I'll turn it over to Rafat, who will come and talk about all of the current options in the frontline setting, to be followed by Nupur, who will talk about relapse therapies, and then Daryl, who will talk about what's happening in Asia, and AJ, who will finish up with all of the exciting new immune therapies. Thanks for being here, AJ. So please welcome Rafat.